Hello everyone. I hope that you have your coffees and cookies ready to enjoy during my presentation. I'm here at DeSoto Falls today. This is about a mile from where I grew up, and I've always enjoyed this space, so I thought it would be a nice place to record my presentation, and I hope that you enjoy it too. My name is Emily Rutledge, and I'm a student physical therapist assistant from Jeff State Community College, and I'm here today to talk to you about vancomycin-resistant enterococci. Over the last 30 years, vancomycin-resistant enterococci, also known as VRE, has become a very dangerous nosocomial infection. We can remember from earlier back learning about opportunistic pathogens. VRE targets hosts with already suppressed immune systems and often manifest into infections that range from mild to severe to life-threatening. So, as physical therapist assistants, we really need to have an understanding of how this pathology affects the disease process, the precautions we need to take in therapy, and how the overall treatment plan is going to be modified because of this infection if our therapy is to be safe and effective. So first I want to talk a little bit about this infection, and then we'll discuss more what this means for the therapist. Enterococci are bacteria that normally live in the human intestines as part of our gastrointestinal flora. It's an anaerobic type of bacteria that is extremely resilient. It can survive difficult environmental conditions like cooler temperatures. It can live in both hypo and hypertonic conditions, as well as both acidic and alkaline environments. So this really makes the human bowel a desirable host for enterococci bacteria. Vancomycin is an antibiotic that has been used to treat many bacterial infections that are otherwise resistant to antibiotics. However, as the enterococci bacteria has evolved, it too has become resistant to many antibiotics, the most recent being vancomycin. As the cartoon on your handout implies, bacteria see this as a big win. Most people will contract VRE in a hospital setting. The bacteria can remain on the surfaces of infected patients' hospital rooms for up to 2 weeks. It is most often spread by direct contact, so not coughing or sneezing, and usually by cross-contamination of the hands of healthcare workers and sometimes contaminated medical devices. Risk factors for developing VRE include being in contact with infected persons, previous treatment with vancomycin, or prolonged antibiotic treatment, hospitalization, especially in intensive care units, previous steroid treatment, having surgery, having a urinary catheter, and undergoing dialysis. VRE can progress to become urinary tract infections and infections in open wounds. Intra-abdominal and pelvic infections can also develop. When VRE becomes most severe, it can cause bacteremia, sepsis, and bacterial meningitis. So obviously, it's really going to depend on the severity of the infection to determine how you're going to rehabilitate. In regards to prevention, we of course, as therapists, would want to screen high-risk patients and quickly isolate those who have VRE colonizations. But really, the most effective way healthcare workers can control and prevent the spread of VRE is by practicing good hand-washing habits. This is so important. And also using personal protective equipment. Now, diagnosis is a little tricky. The procedure includes a fecal swabbing and then growing the cultures for 48 hours. But because enterococci are part of the gastrointestinal flora, patients can test positive for VRE because of colonization, but not have an actual infection. As I mentioned earlier, the success of the treatment is highly dependent on the severity of the secondary infection caused by VRE. Medical treatment includes antibiotic therapy. I came across a really interesting article that described a study in which patients were given yogurt with probiotics every day for 3 weeks. After 8 weeks of follow-up, 8 of the 11 were clear of VRE. Now, I thought this was really interesting because they think the mechanism for this is that the probiotic binds to the intestine walls and prevents colonization of VRE, and that the probiotic also competes with VRE for sugars, which slows the bacterial growth of VRE. That may become an alternate therapy in the future with more research. So now that we have discussed what VRE is, the disease process, and how it is treated, I want to discuss what this really means for the therapist. I cannot stress enough that the level or degree of disease is going to determine how a PTA approaches treatment. If it becomes a urinary tract infection, which is most common, we're going to be looking at treating neuromuscular pain and connective tissue dysfunction. We also want to increase overall tissue oxygenation and maintain balance, posture, and locomotion. We may use pelvic floor exercises, postural stabilization, and flexibility exercises to increase trunk range of motion. If bacteremia or sepsis develops from the VRE infection, we're going to focus on cardiopulmonary, treating edema and impaired skin integrity. The therapist should be cognizant of decreased oxygenation of tissues and should consider manual lymph drainage and compression pumps, bandages, and garments. Also, e-stim for edema and pain may be indicated. If VRE infection develops into bacterial meningitis, it becomes severe and potentially life-threatening. The PTA is going to be concerned with treatment of the neuromuscular and integumentary systems. Common symptoms may be difficulty breathing, decreased aerobic activity, impaired muscle performance, impaired peripheral nerve integrity, decreased sensation, edema, inflammation, ischemia, and pain. If a patient has VRE infection that becomes meningitis, it's likely that the physical therapy will begin in an intensive care unit. The therapist should be aware of marked changes in consciousness. As we have been learning in class, monitoring vitals closely is a critical component to therapy in ICU. Therapeutic exercise should be light and basic, beginning with bed mobility and range of motion. The goal here is to relieve stiffness, pain, increase tissue oxygenation, and promote skin integrity. Breathing strategies may also be incorporated to improve ventilation and improve tissue oxygenation. E-stim may be used for edema, pain, and muscle re-education, and cryotherapy may also be effective at decreasing pain and inflammation. So, in summary, although the overall treatment of VRE is generally successful, it may be difficult to treat because VRE is resilient, invasive, and is an opportunistic pathogen. The PTA really has to understand the severity of the progression of the VRE infection because different stages of the infection require different considerations to treatment, including the plan of care, the precautions to therapy, and the disease process. Focus should be on neuromuscular, cardiovascular and pulmonary, and integumentary systems of the patient with VRE. The rehabilitative plan of care should be tailored to address preventing disabilities, improving functional limitations, relieving symptoms of physical impairments, and restoring the patient to the highest level of function. So now, in closing, I have a couple of questions for you. I came across an alarmingly scary study when I was researching for VRE. I would like for you to give these questions a few minutes of consideration. You can post your answers on the discussion page in the Questions for Emily folder. The questions are: this study reported that nurses wash their hands roughly what % of the time after patient contact? What was the reason for not washing? And finally, what is the average time that healthcare workers actually spent scrubbing their hands? Thank you for answering the questions, and thank you for participating in this MicroTeach. I hope that you have enjoyed the presentation, the view, and the coffee and cookies. Thank you.